陳醫生介紹，今日好開心可以有呢個機會參與個 ChildSim Talk 啦。咁想介紹下李淑嫻醫生。咁其實就我識咗佢好多年㗎啦，因為其實之前一齊喺 QE 一齊做，咁其實佢都係之前教咗我好多嘢嘅。咁就佢係伊利沙伯醫院嘅兒科心臟科顧問醫生啦。咁我哋今日個 topic 好長，我慢慢讀下。Perinatal Management of Patients with Severe Congenital Heart Disease before transfer to Children's Hospital。咁麻煩啦，李醫生。
好，各位好。Actually, we can see we have an upcoming challenge. At present, we can have intra-uteral transfer fetus with severe congenital heart disease to cardiac center of Queen Mary. But such transfer is not possible when the cardiac team of Queen Mary moved to the Children's Hospital for a few years before the new acute hospital opens next to it, because there is no obstetric unit in the Children's Hospital. So stabilization of patients with severe heart disease after birth must be done at individual regional hospitals. So therefore, I choose this topic for today. So fetus with severe congenital heart disease, for perinatal management, we can divide it into two parts. One is on fetus and the other is on the pregnant mother. For the fetus, we will provide prenatal counseling, planning of delivery, and postnatal management of the baby immediately after birth. But for mothers, sometimes they may themselves have severe congenital heart disease as well. So we have to assess the fitness of the pregnancy, assess the fetus for any congenital heart disease, because congenital heart disease may be genetic in origin. And we also need to closely monitor the maternal cardiac status during pregnancy. But because the scope is too large, so today I will concentrate on the part of the fetuses. So on fetal heart disease, we will provide detailed explanation of the heart lesions and the treatment options to the parents, and then we will help the obstetricians to formulate the management plan. So usually the mother will consider whether she wants to continue or terminate pregnancy if the heart disease in the fetus is very severe. If she opted to continue, we need to discuss the delivery plan with obstetricians and the patient. And the other thing is we need to set priority between the mother and the fetus in case the mother get very worse during pregnancy and before delivery. Which one to say first is important. And the immediate postnatal management plan is important. So we need to liaise with neonatologists, pediatric cardiologists, and obstetricians so as to provide the baby with the best chance of survival and treatment outcome after birth. And during the process of counseling, the parents may ask other questions, like the long-term outlook of the baby. So we need to provide them with local experience on the growth, schooling, work, marriage, and future pregnancy of the baby after birth. And usually they will ask why, and how about the next pregnancy, the recurrence risk. So when we talk about postnatal management, we need to understand the timing of presentation of different severe congenital heart diseases. And this is related to the transition of circulation from the fetus to the neonate. So there are 4 types of presentation as far as timing is concerned. So we will, some of them will present immediately after birth. They become critically ill just after birth. But some may present 2 to 3 days later. And some may develop heart failure only 2 to 4 weeks after birth. And these lesions are dependent on the pulmonary arterial pressure. But for a lot of them, they may still be asymptomatic during the entire neonatal period. So we will concentrate on the first 2 groups because these are the most acutely ill patients that we need to manage before transferal to the Children's Hospital in future. So for the first group, if they become critically ill immediately after birth, they can either be having severe cyanosis or severe heart failure or shock. So for those with severe cyanosis, this may be due to restriction of oxygenation mixing in a parallel circulation situation in TGA, or in those with severe obstructed anomalous pulmonary venous drainage. For those presenting with severe heart failure, they can have severe valvular regurgitation like severe Epstein's anomaly, myocardial failure, fetal or neonatal arrhythmia, or those with obligatory shunt. That means the shunt is not dependent on pulmonary arterial pressure. For babies presenting 2 to 3 days later in life, usually it is a ductal-dependent lesions. So they can suddenly become ill when the ductus closes. Usually this occurs at day 2 or day 3. They can present with shock or present with severe cyanosis, depending on the heart lesions they have. So let's look at the ductal-dependent lesions. There are different types. So the first one is ductal-dependent pulmonary blood flow. Usually they will have severe right ventricular outflow tract obstruction, those with pulmonary atresia, critical pulmonary stenosis, tetralogy of a fellow with severe pulmonary stenosis, complex heart with severe right outflow tract obstructions, or tricuspid atresia, severe Epstein's anomaly, and pulmonary stenosis. Or they may be a ductal-dependent systemic circulation, so this is left outflow tract obstructions. The commonest type is coarctation of aorta. The most severe one is hypoplastic left heart syndrome. They can have ductal-dependent oxygenation lesions, so this is transposition of brake artery. But this one will not like the other ductal-dependent lesions that will present later. They usually present on the date of birth, because it's not just ductal lesions, not that simple. So let us illustrate the management with some case examples. The first one is 20 weeks, 3 days. This is a twin pregnancy. So this is a bit difficult for prenatal diagnosis. The one on the left side of the mother has congenital heart disease. So you can see this is the left atrium, descending aorta, left ventricle. This is the right ventricle. But you can see the right ventricular cavity is diminished, but with increase in muscle mass at the apex of the right ventricle. So the baby moves a bit, so this becomes a right ventricle this time. You can see moderate tricuspid regurgitation. From this video, you can see this is right ventricle. This is main pulmonary artery. Pulmonary valve is here. You can see the very thickened pulmonary valve, although you can see some opening of the valve here. So we can see positive blood flows through the pulmonary valve, but it's narrowed at the annulus. The jet is narrowed here. But you can also see retrograde flow from the ductus. So this signifies that this patient has quite severe pulmonary stenosis. When we measured the aortic annulus, it is 4 mm, quite normal in a 20-week fetus. But the pulmonary valve annulus is just 1.8 mm, so it's quite narrowed. So this baby has severe pulmonary stenosis, but not yet up to critical pulmonary stenosis, because there is still positive pulmonary forward blood flow. So we will explain the treatment options to the parents. The mainstay of treatment is to open up the obstructed pulmonary outflow tract. But before that, we need to keep the ductus open before we can proceed with the procedure. And what sort of treatment can be available, either interventional or surgical. So this must be done soon after birth. And the time of recovery will depend on the types of treatment. Like intervention, it will be faster. Surgery may take a bit longer time for total recovery. Success rate is usually high if the RV size is good, like this baby. So of course there are some complications. So what happens during the rest of the days during pregnancy? Most of these fetuses will remain well in utero. In the advanced country, like in the States, pulmonary valvuloplasty in the fetus is possible, but this is not possible in Hong Kong yet. So how about delivery? When to deliver, where, and how? So according to the American Heart Association recommendation, we can categorize fetuses with severe congenital heart diseases into 4 groups. The first one is not very severe congenital heart diseases with expected no hemodynamic instability after birth. So like this VSD, simple TOF, so they can be delivered normally. The second group is those with minimal risk of hemodynamic instability at the delivery room, but they may need early neonatal management. So the example is this baby with ductal-dependent severe right ventricular outflow tract obstruction. So we need to consider the planned induction near term so that we can gather the expertise together to help the baby. And the baby needs to be delivered at centers with neonatal cardiology and neonatal transport expertise, because this baby will need to be transferred to the cardiac center soon after birth. So the long-term outlook, if this is a corrective type of treatment, the baby remains well after intervention or surgery, and the baby has a good RV size, they can live normally with normal growth, they can live a normal life with normal schooling, etc. How about the recurrent risk? So for most congenital heart diseases, the cause is multifactorial. That means interaction between genetic and environment. 70 to 80% of these babies occurred in an isolated manner. Only 20 to 30% of them will have associated genetic disorders. So this is information from the Medical Journal of Australia. So some babies will have chromosomal abnormalities, like those babies with Down syndrome, Edward, Patau, Turner. They have a common associated cardiac lesions. Some of them may have microdeletions or single gene disorders, like Alagille syndrome, Noonan, Hod Oram, etc. And the recurrence risk, so if both parents are healthy, non-consanguineous, if only one child is affected, the recurrence risk for the next child will be 2 to 3%, up to 6%. But if there were already 2 affected children, the recurrence risk for the third one will be 3 to 10%. If the father is having congenital heart diseases, the offspring will have a recurrence risk of 1 to 5%. But if the mother is affected, the recurrence risk is much higher, 2 to 20%. So, of course, the parents will be shocked, confused, have some negative feeling after the fetal condition is disclosed to them. So we need to also take care of their psychological problem. So usually obstetricians will recommend amniocentesis to look for any karyotype abnormality. And for this baby it's normal, and we will hold a perinatal meeting between the obstetricians, neonatologists and cardiologists to plan the best mode of delivery and postnatal care for this baby. So finally this baby was born at 25 weeks 3 days by lower segment cesarean section. The baby was transferred to the NICU. The baby developed some respiratory distress after birth and was put on 25% oxygen. So echocardiogram was arranged as soon as possible. It confirmed the antenatal diagnosis. So you can see the RV cavity is smallish with increased muscle mass at the apex, quite severe tricuspid regurgitation. The gradient of this is more than 100. That means the RV pressure is more than 100. That means it's more than systemic pressure. It's a suprasystemic RV pressure. That means the pulmonary stenosis is quite severe. You can see this is the LV. It adopts a D-shaped configuration. And you can see the septum is flattened, especially during systole. That means this is RV pressure overload. And we can see the pulmonary valve quite clearly. So you can see these 2 cusps are fused with a raphe here. So in effect, this is a bicuspid pulmonary valve. And you can see the opening is not that small, but of course it's much smaller than the original pulmonary annulus. You can see forward pulmonary blood flows through this stenotic pulmonary valve, and also blood flow to the pulmonary arteries is augmented by ductal flow here, a left to right shunt. So this is similar to the prenatal finding. For the pulmonary valve stenosis, the gradient is quite high, it's 72 mm mercury. So this is a severe pulmonary stenosis, not yet up to critical. In critical pulmonary stenosis, there will be very minimal forward pulmonary blood flow. But if the ductus closes, the baby can deteriorate quite significantly. So we will care the baby in the NICU, assess the vital signs, provide resuscitation if needed, physical exam to look for other abnormal findings in other systems. ECG, X-ray, echo, look at the electrolyte, metabolic status of this baby. The aim of stabilization in the NICU is to maintain adequate oxygen saturation, circulation, myocardial function, and cardiac rhythm in the ill baby. So this is a summary of what stabilization modalities we can provide. So if it's a ductal-dependent lesions, we can administer prostaglandin to maintain adequate pulmonary blood flow if there is severe RV outflow tract obstruction, to maintain adequate circulation if there is severe left ventricular outflow tract obstruction, to maintain adequate oxygenation for parallel circulation situation. If a patient has shock or severe heart failure, we need to administer diuretics and inotropes. If the baby has quite severe heart failure and the baby has put on prostaglandin, the baby may develop apnea, so elective intubation and mechanical ventilation is needed. If the baby has severe pulmonary hypertension, nitric oxide may be needed. If the baby needs a good atrial communications to maintain adequate circulation, like in hypoplastic left heart, or maintain adequate oxygenation like transposition of great artery, we need to perform balloon atrial septostomy. If the baby has incessant arrhythmia causing depressed myocardial function, oxygenation, circulation, antiarrhythmic is needed. So actually we can also provide ECMO if the baby is too bad, but of course this is not easily available in the regional hospital. So after looking at this, how would you manage the baby we're discussing? So because this cyanosis is quite severe, we envisage that if the ductus closes, the baby will deteriorate. So we put the baby on prostaglandin. We cannulate the umbilical artery and vein to monitor for his blood pressure and also to administer medications. So the baby was stabilized with a good saturation, blood pressure okay, heart rate okay. So the baby was escorted by our resident and nurse on the same day to Queen Mary Hospital. But because the baby was born at noontime, so after stabilization, the baby was transferred at night time. So not very good for our colleague in Queen Mary. So, but the whole process is smooth because we know the diagnosis up front and we also manage this baby as soon as possible after delivery. So baby need ventilation on arrival because the baby developed apnea later on. And percutaneous pulmonary valvuloplasty was arranged very soon afterwards. And this valvuloplasty was very successful. RV pressure was reduced from 200% systemic to only 84% systemic. The baby stayed for 8 days, gradually improved, and then referred back for us to deal with his social problem. So this is a good, happy ending for the baby. The next case is 26 weeks, and we were consulted for congenital heart disease in the fetus. So you can see that this is the RV, LV. The right heart is much bigger than the left heart. So usually right heart is slightly bigger, but this is abnormally bigger in the fetus. And there is a big ventricular septal defect, measuring 5.3 millimeter. The cardiac function is okay, and this is the pulmonary valve annulus, 5.8 millimeter, quite normal in this gestation. But the aortic valve annulus was just 2.8, and actually you can compare the aorta and the pulmonary artery. The aorta is much smaller, and you can also see this aortic arch. It is also very hypoplastic. We zoom at the aortic arch closely. We can see narrowed ascending aortic arch and the descending aorta, and also there is a discrete narrowing here signifying coarctation of aorta. So a patient with VSD and hypoplastic aortic arch and coarctation. So of course the treatment will be to open up the obstructed outflow, close the VSD after birth. And usually this has to be done in stages because it's difficult to close the VSD just after birth. So usually we will repair the coarctation. The surgeon may also do pulmonary artery banding to limit the VSD shunting so that VSD can be repaired a few months later. So the time of recovery will depend on these different type of operations. So for isolated VSD, mortality risk is very low in Hong Kong, good survival. Coarctation in isolation, also good survival. Of course, complication is possible. But in this patient, there is a combination of lesions, and also the arch is so hypoplastic. So the risk will be a bit increased in this baby. So how about the delivery plan? So this baby is similar to the previous one. He belongs to this risk 2 group. So he may need early neonatal management, coarctation or with severe AS. So the baby needs to be delivered in a center with this type of expertise. So antenatal diagnosis showing normal karyotype. Baby was born at 38 weeks, and she was transferred to the neonatal ICU. SpO2 was normal, pink in air, but the femoral pulses were weak. So we measured the following blood pressure. You can see a very significant pressure difference between the upper limb and the lower limb. This one is more than 20 millimeter mercury. And this is the chest X-ray, UVC in situ. You can see slightly big heart and also mild congested lung fields. This is the ECG. What is the abnormality? The most striking thing is here. You look at V1R and V6S. So very prominent V6S and very little R in V6. So this is severe right ventricular hypertrophy, adductor dependent circulation. So echo afterwards showed the same finding, so diagnosis was confirmed, and the baby also has slightly depressed cardiac contractility. So and also we look at the saturation. We found that the upper limb saturation was less than the lower limb saturation. So the reason is that the lower limb is supplied, the lower limb is less than the upper limb because the lower limb is supplied by deoxygenated blood from the ductus. So there is a differential oximetry in this type of coarctation. So how would you manage this patient? So look at these modalities. What would you choose? So you can see this is coarctation, inadequate circulation. So we will administer prostaglandin. The patient has poor cardiac function, so we will administer inotropes. The patient has such a bad heart function, we will also electively intubate the patient with mechanical ventilation. So after stabilization, the patient improved, and we put in the upper limb arterial line and lower limb arterial line, and actually we can compare the blood pressures. So these are very easily understandable. The upper limb blood pressure is much higher than the lower limb. So after inotropes and prostaglandin, the femoral pulses become stronger and the perfusion improved. So the baby was ready for transferal. So this baby was stable on arrival, and coarctation repair and PDA ligation was possible 1 day later. The operation was very successful. The baby became better. But still the baby has VSD. And unfortunately, the baby developed quite severe heart failure 2 weeks later with bad shape. So the baby required repair of the VSD. But this was a complicated situation. The baby, despite repeated attempt of surgery and resuscitation, even ECMO, the baby cannot make it. But this is a tragic case, but for sometimes, usually the prognosis is good for this type of lesions. But for this baby, the aortic arch is so narrow, so it's a bit difficult. So the third case, 22 weeks, also referred for fetal congenital heart disease. So you can see the prenatal echo. This one is quite clear. This is LA, descending aorta, LV, this is RV. So you can see a patent foramen ovale. So coming up are the great arteries. So you can see these great arteries. Can you see the bifurcation? So this is pulmonary artery. It comes from LV. And this is the aortic arch. It comes from RV. Sagittal view shows that this is the anterior RV. It gives rise to the aortic arch. This is not the ductal arch because you can see the bifurcated great artery, the pulmonary artery, is posterior. So this is aorta. So aorta anterior, pulmonary artery posterior. So this is the D-transposition of great artery. So the treatment options is, of course, surgery, arterial switch to switch the pulmonary artery and the aorta to the right to the right place after birth, and also reimplantation of a coronary artery. Usually this will take place at around 1 week of life, and usually the baby will take around 2 weeks for recovery. So the success rate without VSD is not too bad, 3 to 4% mortality rate only. With VSD a little bit higher, the complications can be coronary event during the implantation or pulmonary artery compression after the arterial switch operation. But generally the prognosis is good. So because for TGA, this patient not just ductal dependent, but they required unrestricted atrial septal communication after birth. So usually the PFO is not very non-restricted, so they belong to a higher risk after birth. So they may need immediate stabilization. So the recommendation is planned induction at term, and we need to consider cesarean section if needed, so that we can gather all the expertise to help the baby. And it's best to deliver the baby at a tertiary referral center with expertise for immediate stabilization, including balloon atrial septostomy. But if the atrial septum is quite intact without much PFO, then the baby needs to be delivered at the center with cardiac surgery. But in future, this is a future few years, when the cardiac center moved to Children's Hospital, this is not possible. So before delivery, we still need to monitor the status of the PFO. If the PFO is very restrictive, the baby will be quite risky after birth. So the baby was born at 38 weeks with lower segment cesarean section. So diagnosis was confirmed by echo. This is the left side LV giving rise to the pulmonary artery. You can see 2 branches. And then this the aortic arch from the RV. So let us look at the hemodynamics, heart rate a bit fast, blood pressure. This one is should be the upper limb one. This is okay. And then the saturation, we connected to preductal and postductal saturation. So you can see there is also a differential oximetry, but this time is different from coarctation. You can see the preductal one is lower than the postductal one. So why is this? Because if the PFO is restrictive, so the oxygenated blood from the left heart can only will be restricted going to the right heart. So only a little bit of oxygenated blood can go to the right heart. So the ascending aorta will be supplied by this mainly deoxygenated blood. But for the descending aorta, it will be supplied from the right heart with oxygenated blood through the ductus. Therefore, the preductal saturation may be lower than the postductal one. So how to stabilize this baby with TGA? So we know that we need to give prostaglandin, but this is not enough. So we also need to improve the atrial communication. So we need to perform balloon atrial septostomy for the baby, and this is introduced in 1966 by Rushkin and Miller, and it's a handy procedure to stabilize sick neonates with restricted atrial communication before transferal for surgery. So we will do it in the NICU. We will sedate the baby, cross-match some blood in case there is bleeding, under echocardiographic guidance, and we need 2 cardiologists to perform it. One will be the operator, the other will help to do the echocardiogram. Actually, which one do you think is the more important person? I think the one who performs echocardiogram is more important, because the procedure is not very difficult, but if you can show very good pictures, the procedure can be easier. So we can the venous access can be through the pulmonary vein. If the umbilical vein, you cannot cannulate the umbilical vein, and we use the balloon septostomy catheter. At the end, we have an inflatable balloon. So we cannulate the umbilical vein. So this video cannot work, I'm sorry. So we put in the, it's too old, so you can't make it. So we put in the catheters through the IVC up into the RA, through the patent foramen ovale, into the LA, and then we inflate the balloon. And then we pull back the balloon with some force to tear this part of the atrial septum. Usually this part is very soft, and then we can create a big atrial septal defect. This is the initial shunting through the PFO. But after the septostomy, you can see a big ASD measuring 6 millimeter was created. So there is enough blood flow into the right heart to supply the ascending aorta. So the baby becomes better after septostomy. So you can see the preductal oxygenation rose up to 90 now, so quite close to the postductal one. So blood pressures are okay. So of course, some risk is associated with balloon atrial septostomy. So this has to be done very carefully under expert hands. So after septostomy, the baby was immediately transferred to the cardiac center for arterial switch operation, which was performed on day 7. So afterwards, the baby did quite well, but the baby developed supravalvular pulmonary stenosis of a gradient up to 80 at around 6 months, and he required balloon dilatation of the stenosis. Unfortunately, the baby did well afterwards, and the baby remained well now. He is 18 months old. So the fourth one, 30-week gestation, this time is something different. The mother was referred for fetal query complete heart block, and she was referred for early delivery. So this is the fetal heartbeat. So it's a bit slow, you can see. So what is this rhythm? Is it a sinus, bradycardia, or complete heart block, or other rhythm? Can we do a fetal ECG? So it's difficult. So we can perform echocardiogram and use M mode to determine the cardiac rhythm. So we can do the M mode through the ventricle and the atrium. Then we can see this is atrial contraction, and this is ventricular contraction. So we can time the atrial rate and also the ventricular rate and look at the atrial-ventricular relationship. So this is the M mode for this baby. So this is the LV. This is the RA. What is the heart rate? Actually, you can see atrial and ventricular contraction rate are quite different. Ventricular rate is around 80 per minute. How about atrial rhythm? Actually, you can see 2 atrial contractions very close together, separated by a pause. So the rate here is very fast, up to 200 something. So how about the atrial-ventricular relationship? You can see this atrial contraction is conducted, so forming this ventricular contraction. But for this one, there is no ventricular contraction following it, so there is a block here. So actually this pattern is repeated regularly like this. So from this picture, I think this is a premature atrial contractions in by Germany. So the premature contraction was blocked because it's too near to the sinus beat. And for this baby, I look at all the other structures. There's normal, chamber size and normal, contractility is normal, and the baby has no hydropic features. So this baby is quite safe to continue the pregnancy. So if we deliver the baby now, it's quite difficult. If the baby has neonatal arrhythmia, difficult to treat this baby. So we will continue to monitor the baby, look at the cardiac condition. So if what we are worrying is not bradycardia, but tachyarrhythmia, because this is atrial ectopic. So we are worrying about atrial tachycardia for this fetus. So if the baby develops incessant tachycardia, we can administer oral antiarrhythmic to the mother before birth. So at 33 weeks of gestation, I repeated the echocardiogram for the baby. So how about the rhythm this time? Do you think that the heart rate is much faster now? So the heart rate now is 146, very good. And also we can see regular atrial and ventricular contraction, and also 1 to 1, this one to this one. So this is should be a sinus rhythm with 1-1 conduction. So we are very reassured looking at after we saw this picture. So the baby was born at 37 weeks of gestation, good body weight. Of course, we want to know the rhythm of the baby after birth. So we did an ECG. So this is a regular rhythm, 124 per minute, not fast, not slow. So are you happy about it? Okay, look at it closely. What rhythm is it? So when you look at V1, look at this is P, and you can see PR is very short, and there is a delta wave. So this baby actually has an accessory pathway in his heart, and this is prone to arrhythmia. So accessory pathway, so causing pre-excitation on the ECG. So this is Wolff-Parkinson-White syndrome or features in this baby. But luckily, there is no arrhythmia. The baby remained in sinus rhythm, only mild NNJ. So in view of the prenatal abnormal heart rhythm, we observed this baby for a longer time. And the baby remained in sinus rhythm for 1 week. So we need to discharge the baby at the end of 1 week. But before discharge, the baby developed this rhythm. The baby did not want to go. You can see 229 per minute. So this is supraventricular tachycardia. So luckily this rhythm can be stopped by ice pack applied to the face. So what is this type of SVT? What sort of mechanism is it? Is it atrial ectopic tachycardia, AV reentry, AV nodal reentry, permanent junctional reciprocating tachycardia, or anything else? So we want to look at the A and V relationship better. So we put in a transesophageal ECG lead into the esophagus. So this is just posterior to the LA. So we can get a very good picture of the atrial wave and the ventricular wave. So this is A, this is V. So we measure the VA interval. This is 110 milliseconds. And the AV interval is longer than the VA, 160 per millisecond. So if it's AV nodal, we will expect a shorter AV interval, less than 70. But now it's more than 70, but this is shorter than the AV. So this is likely to be a retrograde atrial wave from the ventricular wave. This is atrioventricular reentry tachycardia. Actually, this is typical of Wolff-Parkinson-White syndrome. So when this baby developed SVT, we use ice pack, but afterwards the baby, after reverting back to sinus rhythm, the baby had a recurrence of SVT again. So we need to give intravenous adenosine. The baby responded well, so we started the baby on oral antiarrhythmics. And while we are titrating the medication dosages, we monitor the baby closely. So we have a cardiac monitor, and we also put in the ECG machine by the bedside, and then connect the leads with, on the limbs of the baby and the chest, so that if the baby develops an attack of SVT again, we can immediately perform an ECG and then look at the rhythm better. So the baby did quite well initially, but later on the baby developed very bizarre arrhythmia, and sometimes couplet, sometimes non-sustained SVT, and sometimes like this. It's a Y complex tachycardia. This is likely an antidromic type of SVT, conductions through the accessory pathway in the antegrade manner. So we need to add other, besides different intravenous medications to stop the SVT, we need to increase the dosages and also add other oral medications. So in the end, the baby required 4 medications to control the supraventricular tachycardia. The baby remained well for some time, but then he developed side effects from the medication. So eventually the baby was transferred to Queen Mary Hospital. In Queen Mary Hospital, the baby also developed frequent attacks of SVT. So he required electrophysiology study and ablation of the abnormal pathway at 2 months old. This is a bit early for EPS, but because this baby's rhythm is so bad, so this was performed. It seems to be aborted, but soon afterwards the arrhythmia recurred again. So the baby was put back on oral antiarrhythmics. Fortunately, 2 medications is enough to stop the SVT. So they were successful in decreasing the medications from 4 to 2. So eventually the baby could be discharged well, and the medications was continued up to 2 years old. And afterwards the medications can be taken off safely, and the baby remained attack-free, and the baby is now 4 years of age. Okay, so management of neonatal SVT. The most important thing is to terminate severe arrhythmia as quickly as possible. So you can use ice pack if you don't have other thing. But if ice pack doesn't help, we need to give intravenous adenosine. So the dosage is starting with 0.1 milligram per kilo with a rapid IV push. So a rapid push is important to make it effective. If it's not very effective, we can increase it every 2 minutes up to 0.5 milligram per kilo. The last time we listened to the lecture of Dr. Sabrina Cho, she reminded us that some babies can develop atrial fibrillation after giving adenosine. Although we haven't encountered this before, but we need to be careful. So this needs to be done in the neonatal ICU as well. So if this is not okay, we can try intravenous amiodarone. If the hemodynamic status of the baby is compromised, we cannot use medication. We need to use synchronized DC version. So if you're not comfortable after the baby returns to sinus rhythm, I think it's better to transfer to the cardiac center as soon as possible. But if you cannot control the arrhythmia in the regional hospital, then I think it's better to ask the expertise from the cardiac center to provide some outreach service to your department to stabilize the patient. Otherwise, if the baby has prolonged SVT, the baby can become very ill and it's difficult to salvage the baby. So the last case, so this baby was, the antenatal follow-up was not done in our hospital. The baby was only referred after birth from private hospital to us for persistent cyanosis. The baby was born by lower segment cesarean section, and the antenatal ultrasound was reported normal. But the baby developed severe cyanosis after birth. He was resuscitated with hand bagging because the saturation was very low, but the response was very poor. The saturation was reported at around 60 or something, 60%, something like that. So when the baby arrived, of course, we need to resuscitate the baby with the usual airway, breathing, circulation. So this baby required ventilation, intravenous fluid. And then we need to differentiate the cause of the severe cyanosis. Physical examination, differential blood pressure, differential oximetry. As we know before, we can differentiate some type of heart diseases from this maneuver. Check the blood gases for any CO2 retention, any metabolic respiratory acidosis. Check the X-ray, ECG. So when we look at newborn babies with severe cyanosis, what are the differential diagnoses? So we can divide it into 3 groups: lung disease, persistent pulmonary hypertension of the newborn, or cyanotic congenital heart disease. So we can look at different parameters, try to differentiate the causes. So for babies having severe cyanosis on day 1, ductal dependent cyanotic congenital heart disease is not so likely because the ductus usually will not close just after birth. So this may be a bit later. But for lung disease, PPHN, and other cyanotic congenital heart disease, this is possible. For lung disease, they usually will have respiratory distress. But for cyanotic heart disease, they may not have respiratory distress. We call this a comfort cyanosis. And response to oxygen ventilation is quite different between patients with lung disease and those with cyanotic heart diseases. For lung disease, usually they will have some response. But for cyanotic heart disease, usually the response is minimal. For PPHN, sometimes they have response, sometimes not. And if you sedate the patient, maybe they will become better. CO2 retention usually occurs if the baby has lung disease, but not in cyanotic congenital heart disease. One particular point in PPHN is the condition can flip-flop very quickly. So this is a particular feature. For PPHN, they will have differential cyanosis. The upper limb's SpO2 will be higher than the lower limb. But for TGA, the upper limb SpO2 will be lower than the lower limb. So for babies with lung disease, they may be having perinatal pneumonia, so there may be signs of sepsis. But for the others, usually not. For PPHN, of course, they may be associated with sepsis. So chest X-ray and ECG can also help us. So for lung disease, of course, you may be able to see the lung lesions. The heart should look normal. ECG should be normal unless they have associated heart problem. For PPHN, if this is triggered by the lung problem, of course they will have lung lesion. Otherwise, they look normal. But because of increased pulmonary blood pressure, there will be RVH on ECG. For cyanotic heart disease with right ventricular outflow tract obstruction, the lung fields will be oligemic, heart shape may be abnormal. Of course, ECG will show right ventricular hypertrophy. TGA, heart shape will be abnormal, and also there will be right ventricular hypertrophy. And for obstructed total anomalous pulmonary venous drainage, the lung fields are congested and the heart shape will also be abnormal, and also the patient has severe RVH. So usually ECG will show RVH. So look at this baby. You can see mild bilateral pneumothorax. We think that this is due to vigorous resuscitation after birth because no matter how hard you back the baby, the saturation cannot go up in this baby. Therefore, the baby developed pneumothorax. And the lung fields show ground glass appearance. After the baby was put on ventilator, the baby was still cyanotic with acidosis, and there was no PCO2 retention. Is this respiratory distress syndrome? This picture is a baby with RDS. It looks a bit different. So our differential diagnosis, and this baby has no fever, no sign of sepsis. So lung disease is not likely. So either PPHN or cyanotic heart condition. Okay, look at the ECG. What is the most striking abnormality? Look at V6. You can hardly see any R in V6, but deep S in V6. That means no LV force, left ventricular force, but prominent right ventricular force. So this is severe right ventricular hypertrophy. So again, the DDX is PPHN and cyanotic congenital heart. But since this baby's cyanosis occurred right after birth, and the lung fields are not oligemic, but instead very congested, so this is not likely a ductal-dependent right ventricular outflow tract obstruction. So we have two differential diagnoses, TGA or TAPVD. So look at the heart shape. This is a typical abnormal heart shape of a snowman. So this is the head of a snowman, the body of a snowman, the ground of the snow, and the lungs are snowing. You can see these dots of snow in the lungs. So this is a classical abnormal heart shape in supracardiac TAPVD, total anomalous pulmonary venous drainage. Of course, echocardiogram is needed to confirm the diagnosis. So this baby has obstructed supracardiac TAPVD. So in this case, the pulmonary veins are here, and the pulmonary vein is not connected to the LA, but connected through a vertical vein to the innominate vein, left innominate vein, and then back to the RA. So this one is cardiac TAPVD, this is infracardiac TAPVD. So usually in supracardiac or infracardiac TAPVD, the pathway are obstructed. But for cardiac one, it usually is not obstructed because it goes back directly through the coronary sinus to the RA. So the oxygenated blood, total oxygenated blood from the pulmonary vein will be mixed with the total systemic deoxygenated blood at the RA level, and then part of it will go through the right heart to the pulmonary artery, and another part goes through the left heart to the aorta. But if this PFO is restricted, then most of the blood will be in the right heart. And also because of the pulmonary venous congestion, there is pulmonary hypertension, so the blood will be congested in the right heart and also in the lungs. So these patients will have pulmonary venous congestion, pulmonary edema, pulmonary hypertension. So this too will cause decrease in cardiac output and severe cyanosis. So these this group of baby will be very ill after birth. So how can we help stabilize this baby before transferal? So the baby's condition is not good, heart function not good, so the baby usually required inotropes, elective intubation, mechanical ventilation, and because of pulmonary hypertension, they require nitric oxide to decrease the PA pressure. If the atrial communication is restrictive, we also need balloon atrial septostomy. Okay, this baby, we corrected the acidosis. We did all these maneuver to stabilize the baby. So the baby become quite well for this one, and we can transfer the baby to the cardiac center. And the only treatment is, of course, urgent surgery to reimplant the pulmonary vein back to the LA. But if you cannot stabilize the baby is too bad, some baby require ECMO. And how about prostaglandin? Can we give prostaglandin to babies with TAPVD? The answer is yes or no. So if the cardiac output is too bad, that means if the pulmonary blood pressure is too high, and also the cardiac output is low, then if you give prostaglandin, you open up ductus so that some part of the blood can go through the ductus to the descending aorta. You can help to maintain the circulation a bit. But afterwards, the baby may become more cyanotic when you give prostaglandin, but you help the cardiac output. But if the cardiac output is not that bad, but the pulmonary venous congestion is very bad, if you open up the ductus, if there is left to right shunt, you increase pulmonary blood flow back to the lungs. You will increase pulmonary venous obstruction and congestion, so the baby will become worse afterwards. So therefore, this one needs to be under careful consideration. So now we come to general approach to critically ill newborn. So if you in your department you don't have echo readily available, or no one can come back to do the echo in a short period of time, if you want to differentiate whether this baby, cyanotic baby, has cyanotic heart or not, we can use hyperoxic test. 100% oxygen for 10 minutes administered to the baby, and then check the arterial saturation. So if it's more than 300 millimeter mercury, it's normal. Of course, for this type of baby, we do not need to do the test. So this is not your consideration. So if it's more than 150 but less than 300, then usually this is lung disorder. If the saturation can be raised up to 100 but less than 150, it's likely either PPHN or cyanotic heart with a cardiac mixing with increased pulmonary blood flow. But if it's less than 100 millimeter mercury, it's very likely that this is cyanotic congenital heart disease, either a TGA or a cardiac mixing with restricted pulmonary blood flow. So if the baby is very bad and you think that this is cyanotic heart, there is no harm trying prostaglandin, because you can help babies with severe right ventricular outflow tract obstruction. And so this is no harm to try it. But if the baby becomes worse, of course you need to stop it. And also you also need to look at the time of presentation. If the baby presents right after birth, ductal dependent right ventricular outflow tract obstruction is not that likely. And also you look at the lung fields. If it's very oligemic, this is likely of help. But if it's very congested already, prostaglandin may not be helpful. But how about if the baby presents with circulatory collapse, not cyanosis? Then we can also differentiate between different causes. Either a ductal-dependent left ventricular outflow tract obstruction, myocardial disease, severe valvular regurgitation obligatory shunt, or incessant arrhythmia. So we also look at the time of onset, whether the baby has respiratory distress. Actually, all of them have respiratory distress. Any CO2 retention, usually no, except in babies with lung disease. Look at differential pulse or blood pressure and differential oximetry. Look for any sepsis. Look at the ECG, chest X-ray. So ductal-dependent circulation, like coarctation, usually occurs later when the ductus closes. So upper limb blood pressure is higher than lower limb. But if it's hypoplastic left heart syndrome, all the pulses will be weak. But it's very rare to encounter this baby because usually in the antenatal period, this is very easy to pick up. ECG will show RVH. Myocardial disease like cardiomyopathy, myocarditis. So the X-ray will show congested lung fields, cardiomegaly. ECG will show left ventricular hypertrophy or biventricular hypertrophy. So severe valvular regurgitation, also congested lung fields and cardiomegaly and so on. If it's a severe arrhythmia, of course, the ECG can show it to you. Okay, in some way, good perinatal management can provide the best chance of survival and success of treatment for babies with severe congenital heart disease. Antenatal diagnosis help us to pick up babies or fetuses with severe congenital heart disease, and we can prepare the parents better, and we can enable a team approach to formulate the best delivery and postnatal management plan for the baby. So as we have no obstetric units in the children's hospital, a close liaison with the future cardiac team in the children's hospital and in the neonatal transport service of Dr. Guan of the children's hospital is most important. Thank you very much.